Okay, great. Thanks. So very good evening, doctors. Thank you for joining in today's wonderful session on the cardiac colloquium, which we conduct every day, which is a national level event where we almost talk about which are the right RAS inhibitor to select in the post-MI patient. So today we have the eminent faculty who will guide us which are the right way or which is the right patient profile in which sort of RAS inhibitor we should use. So without further ado, I will just introduce the our today's moderator, Dr. Rohit Parthi sir, who has been working as a senior consult interventional as a cardiologist in the Alchemist Hospital, and before that he was associated with the other hospitals like the Silver Oaks, the Mukut Hospital, and add on to that he has been conducted in a very large angiographics like 8,000 plus angiography has been conducted 3,500 plus coronary and peripheral angioplasty he has done. And so much more, the accolades are with the Dr. Rohit Parthi, sir. So we welcome you, sir, and thank you so much for, joining us in today's cardiology session and, to guide as a moderator in today's session, sir. Thank you very much, sir.
Thank
And
you.
and followed by we have the the expert panel for the today's cardiac with Dr. Rohit sir, Dr. Arvind Singhal sir, who is a senior consultant and the interventional cardiologist at the Metro Heart Institute at Faridabad. Dr. Abhishek Sharma sir, who is senior consultant interventional cardiologist at the Apollo Spectra Hospital and at the Ratan Jyoti Dalmia Heart Institute from the Gwalior. And we have Dr. Kamaldeep Bansal sir, who is a DM cardiologist, gold medalist, senior consultant cardiologist from the Sacred Heart Hospital from Jalandhar. And we welcome all of you, the three experts, and thank you so much for accepting our invite in today's cardiac colloquium. So before any further ado, I will hand over this session to Dr. Rohit sir to moderate the session and quickly let us know what are the guidelines and then followed by the panel discussion, sir.
Oh, I think everybody is there. Three of our colleagues are there, or still somebody is joining?
So we have Dr. Kamaldeep sir is there, Dr. Arvind sir is there.
Okay.
Just Dr. Abhishek sir is yet to join. He is occupied somewhere, but he will join in meanwhile in just
Okay.
next 5 minutes, sir.
So, dear colleagues, friends, and people from MCure Scientific Division. So, today is a very important topic which is often missed by the ARNI age. I will call it ARNI age because every left, right, and center ARNI has been prescribed. But today I will just go through the scientific data whether ARNI is required everywhere or we can still go with ACE inhibitors or ARB in specific groups. So optimal selection of RAS in post-MI patients. We will mostly talk about post-MI patient and heart failure due to MI. So main RAS inhibitors, as you can say, is ACE inhibitors, ARNI, ARBs in post-MI patient. What do current guidelines say? So starting from the era when ARBs came, Optimal was a RCT randomized controlled trial which was done in 2002. Losartan 50 mg once daily versus captopril 50 TDS was studied, and no non-significant difference in total mortality in favor of captopril was proved. So losartan was considered equivalent to captopril, and Valiant Valsartan, which is the most effective ARB, as everybody knows, in heart failure, was compared to captopril in who are at high risk for CV events after MI. Combining Valsartan with captopril increased the rate of adverse event without improving survival. So So optimal trial which was done on losartan, when it was compared with captopril, one can see that endpoint was uh, secondary endpoints and primary endpoints was lesser in captopril group as compared to losartan. So non-significant, but the difference was non-significant, but was in favor of captopril. ACE inhibitors should still remain first choice of treatment in patients of complicated acute MI, mostly anterior wall MI, and losartan cannot be generally recommended in this population except for patients who have adverse events of ACE inhibitors like angioedema, drive cough. Valiant again, valsartan, mortality from any cause and cause specific mortality was similar in three treatment groups. One was captopril group, other was valsartan, and one was valsartan plus captopril. So mortality by treatment again almost same, and events were lesser in captopril group over the period. And then CV death, MI or heart failure by treatment, again the difference was not much. The rate of secondary endpoint of death from cardiovascular causes, recurrent MI or hospitalization for heart failure was similar in three groups. Now we go on to ARNI. So ARNI following acute MI was studied in Paradise MI trial, which was done by Mark A. Pfeffer, professor of medicine in Harvard Medical College. So inclusion criteria in Paradise MI was acute MI within 12 hours to 7 days with LVEF less than equal to 40% with pulmonary congestion, plus any risk enhancer like age more than 70 years, EGFR less than 60, diabetic, prior MI, atrial fibrillation, LVEF less than 30%, CLIP class 3, and STEMI without reperfusion. So high risk acute MIs were in the inclusion criteria, and major exclusion was if the patient had earlier episode of heart failure, he is clinically unstable, EGFR is less than 30. So one was sacubitril valsartan group where 100 mg, 200 mg twice a day dose was used, and ramipril in other group, the other group target dose of ramipril 5 mg twice a day was used. So no run-in period was there, double-blind active control study was there, event-driven 7 double one primary endpoints were there, and median follow-up was 23 months. So CV death, first hospitalization due to heart failure or outpatient heart failure was events were lesser in ARNI group with the p-value was not very significant but 0.17. So I mean to say high risk patients of acute MI, heart failure, age more than 70, diabetic, prior MI, AF, LVF less than 30, no reperfusion therapy done. No, ARNI was a little bit better than ramipril. So primary outcome, as you can say, was 11.9% as compared to 13.2%, which we already discussed, p-value of 0.17. Again, CV death was also less. Hospitalization heart failure was also less. Outpatient heart failure was also less, though their p-values were not very significant. Adverse events, um, again, angioedema was almost same. And then adverse events, hypotension and cough was more in ramipril group, hypotension was more in ARNI group. Rest, hyperkalemia, renal impairment, liver abnormalities, almost same. Summary of Paradise MI trial is sacubitril ARNI did not result in significantly lower risks of CV death, heart failure, hospitalization, or outpatient heart failure. Pre-specified observations of reduction in both investigator reports of primary composites as well as in the total educated events support in my population was comparable to that of ACE inhibitor. This high risk population, one can even use ARNI and it is better. So ARNI doesn't surpass ACE inhibitors after acute MI. Um, so this makes me a question that does ARNI of benefit in acute MI settings? So ACE post MI trials, as we all know, it was high risk patient was studied in SAFE trial where ejection fraction was less than 40% and air in TRACE, clinical heart failure, TRACE wall mission score, EF less than 30%. The short term has and broad spec consensus to GC3 and ISI is 4. So SAVE trial where we had used captopril, survival and ventricular enlargement study. So MI with LVF less than 40% were randomized after 3 days and between 16 days of acute event. Muga baseline at 36 months was done. Captopril 50 mg TDS versus placebo was studied. Follow-up period was between 2 to 5 years. So results showed captopril showed 19% reduction in mortality and 25% reduction in recurrent MI. The cavity dilatation was reduced. These benefits occurred equally in patients who received lysis plus beta blockers and in those who did not. The TRACE again, Randopril cardiac evaluation study, which is not used in India, this molecule, but again, its result have shown that wall motion index was in the population wall motion index was less than equal to 1.2. Tildalopril 1 mg per day, maximum of 4 mg was studied with against placebo. There was 25% reduction in mortality, 15% reduction in recurrent MI, and 20% reduction in sudden cardiac death. Now, captopril was also studied in other ISIS-4 trial. It reduced 5-week mortality and survival advantage appeared to be maintained in long term. Lisinopril started within 24 hours after MI, and it was in GC3, and mortality and severe LV dysfunction was less. In CCS1 trial, anterior infarction on captopril treated group was found to have lower mortality. AIR trial was again, that was on ramipril versus placebo, acute MI with transients on persistent heart failure was randomized between 3 to 10 days and follow-up of 15 months was done. So you can see in the graph that ramipril showed 27% reduction in mortality and 19% reduction in MI and stroke at 6 months. Year extension study, randomized double-blind placebo-controlled multi-center study where 603 patients who participated in AIR study was done, and this study was up to 5 years. Beneficial effects of ramipril started early after MI with heart failure and were sustained for 3 to 4 years despite discontinuation of medication at 1 year. So even if you stop the ACE inhibitor at 1 year, its beneficial effects are sustained over 3 to 4 years. So relative risk reduction in mortality of 36% and absolute risk reduction was 11%. So once you treat 9 patients with ramipril for an average of 1 year, we result in one additional survivor to 5 years. This again 11. So AIR acute infarction ramipril efficacy in acute MI with transient or persistent heart failure was randomized between 3 to 10 days. Oral ramipril versus placebo was studied. I think this we have already done. Extension study where beneficial effects of ramipril started early after MI with heart failure and are sustained for 3 to 4 years despite discontinuation of 1 year after 1 year. Again, there was 36% uh, risk reduction when we compared with placebo. So ramipril's long-term survival benefit in acute MI patients complicated by heart failure was studied in a recent AIR survival study in 2021. So 603 patients were taken and no intervention was done. Duration was for last 30 years. Life expectancy or all-cause mortality was primary outcome. The results of year survival were median survival period was 8.3 with placebo, 9.6 year with ramipril. Extension of life was around 14.5 months. The survival curves cross at 14 years. You can see the survival curves cross at 14 years in favor of almost placebo, and ramipril became the same. So life expectancy was greatest at about 15 years. So life expectancy was improved with ramipril across the comorbid groups. So life expectancy in diabetics, when we compare the diabetic group, it was 32.1 versus 5.0 in favor of ramipril. Previous MI 20.1 versus 4.9 in placebo group. History of heart failure 19.5 versus 4.9. History of hypertension 16.6 versus 8.3. Angina 16.2 versus 5. And age more than equal to 65 versus less than 65. Again, 11.3 versus 5.7. So substantial survival gains with ramipril treatment for 15 years beyond the blinded treatment allocation was seen. Overall, for every day a patient received ramipril on average, his or her life was extended by a further day. It's very good observation. Relative risk of survival for patients with diabetes was increased by 54%. So diabetics uh, have more usefulness of ramipril. Patients with diabetes, previous acute MI, previous heart failure, hypertension, and angina each benefit on average from ACE inhibition. Treatment with ramipril for about 1 year when started early post AMI in patients with heart failure results in survival benefit, which is sustained over many years and offers on average an extension of life of additional 1 year. Concluding remarks, treatment with ramipril for about 1 year when started early post AMI in patients with heart failure results in survival benefit which is sustained over many years and offers an average and extension of life of additional 1 year. What do the current guidelines suggest? So time-dependent therapies of post-MI infarction heart failure. So initially, if patient presents with heart failure at 0 hours, the immediate reperfusion should be done, either coronary angioplasty or thrombolysis. And in cardiogenic shock, primary angioplasty as a choice. Early initiation of ACE inhibitors within 24 hours. It causes 40% of survival benefit from ACE is conferred on the first day. If we start ACE inhibitors within 24 hours, after and about 24 hours, you start beta blockers for first 24 hours for ongoing heart failure, except in patients who have severe heart failure or cardiogenic shock or bradycardia. Then our MRA, within 7 days, it should be started. Re-evaluate eligibility of beta blocker therapy throughout hospitalization. Please try to start as soon as possible. And at discharge, titrate the doses of ACE inhibitors, beta blocker to optimal levels in the post-discharge time also. You keep on increasing the dose every 2 weeks. So early ACE therapy should be the crux to for survival benefit. So JAC acknowledges AIR first April study 1993 Lancet, where early use within 24 hours of of MI, high dose of beta blockers is harmful, should be avoided in MI in heart failure or high risk for cardiogenic shock, age more than 70, systolic BP less than 120, sinus tachycardia more than 120, and heart rate less than uh, 60. ACE inhibitor should be administered within first 24 hours for any MI with heart failure less than ejection fraction less than equal to 40, heart failure patients or EF less than 40, significant survival benefit, 40% comfort on the first day of treatment. Early initiation is important. Only contraindication is systolic BP less than 100, acute kidney injury, renal failure, and drug allergy like angioedema. ARB should be used only where ACE inhibitors are not suitable. Aldosterone antagonists like eplerenone should be started less than 1 week for patient with ejection fraction less than 40 and heart failure for reduction in mortality and sudden cardiac death. Effects of eplerenone was time dependent and affected if drugs are or added 7 days after MI. Contraindication again were creatinine more than 2.5 in men and 2 milligram in women, potassium of more than 5. Early revascularization is the only therapy proven to reduce mortality. And in MI setting, routine use of IVP is not indicated to reduce infarct size or to manage cardiogenic shock. So ESC guidelines for management of acute coronary syndrome in patients presenting with persistent ST elevation, in patient presenting without persistent ST elevation, ESC 2020. Again, ACE inhibitors are recommended in patients with less than ejection 40% ejection fraction, diabetes, or CKD unless contraindicated, like severe renal impairment, hyperkalemia, in order to reduce all cause and cardiovascular mortality and cardiovascular mortality. Beta blockers are recommended in patients with systolic dysfunction or heart failure with MRA again in ejection fraction less than 40 within 7 days. Now, these are ASA's latest guidelines in February 2025. Again, ACE inhibitors are class 1A indication, and in patients with ACS and LVF less than 40 with heart failure symptoms and or diabetes, MRA is indicated to reduce all. MRA is 1B, and then in patients with ACS who are not considered high risk, an oral ACE inhibitor or ARB is reasonable to reduce MACE. uh, Class 2A indication, ARNI does not find any mention in these. So I sum up my discussion by saying that one should consider ACE inhibitors post MI uh, as the basic first line drug wherever possible, followed by beta blockers
Hello.
and then consider ARNI only in high risk patients where anti-proBNPs are high or they have still persistent heart failure. There we can add ARNI, replace ARNI. We can have a discussion on this talk now. Am I audible?
Yes, sir. Yes, sir. We can start, sir. We can start.
So Dr. Arvind Singhal is there.
Yeah, Arvind sir is
Yes,
there, sir.
yes. Good evening,
Hello,
sir.
hello. Good evening, Ji. Good evening.
Hello. Good evening, all doctors and panelists.
So this is just the revision of all the slides that when after MI, at what systolic BP one should initiate is therapy. Mainly we are using Ramipril, and at what dose and how do you up titrate the dose? Sir,
Yes.
when do you introduce the Ramipril in your therapy of acute MI?
Yeah, yeah.
At
It has
what
been nice
systolic?
presentation by Dr. Rohit. Basically, we prefer the start the ACE inhibitor within 24 hours of the
Right,
after the
sir.
acute MI.
Right, sir.
Uh, Ideally, we start low dose ACE inhibitor like Ramipril 2.5 mg only when patient recommended BP is at least 100 systolic BP.
Yeah.
Then we gradually in, titrate the dose of the cardiac when
Yeah.
patient tolerate the blood pressure.
Very rightly said. One should not be very keen to just follow the guidelines. I have to start the Cardace, Ramipril.
Yeah.
Uh, Please allow the patient to be a little bit hemodynamically stable, at least a systolic blood
Yes.
pressure above 100. And then
Yes.
you just up titrate the dose once before discharge. If you can see there is some scope of increasing the dose, then subsequently on follow-up, guidelines suggest 5 mg twice a day. But in my clinical practice,
Yeah.
I hardly find patients who can tolerate such doses because these trials have been done on Western population where body surface area of the patients is more. Dr. Arvind, do you agree that we are not able to, personally, I am not able to give the optimal, the maximum tolerated dose is not, matlab
Yeah.
I cannot reach about
Um,
10 mg.
Maximum patient could not tolerate the 5 mg BD dose,
Mhm.
usually in the post-MI patient.
Yeah. Chalo, we'll go on to the next. Dr. Abhishek Sharma
No,
is there?
I will start with 5 mg, then gradually increase to 5 mg.
Yeah. So will
Yeah.
you, Dr. Abhishek will just briefly discuss, will you switch the patient to an ACE inhibitor if the patient is during the time of myocardial infarction already receiving a ARB for hypertension? In your clinical practice, suppose he is already on telmisartan or losartan, will you switch on to ramipril in all patients?
Abhishek sir. Maybe Arvind sir can highlight these points.
So I'll just discuss it briefly that it is not necessary to switch all patients on ARB who have suffered MI because switching from ARB to ACE inhibitor should only be done where it is really required because why to disturb the hemodynamics which he suppose some patients who have, we have to stop ARBs because of initial hypotension. There we can introduce ACE inhibitors now. If the patient has a small MI, maybe in lateral wall MI, where the blood pressure did not drop and ejection fraction did not drop, we can continue ARBs. So specific population is when patient has heart failure symptoms, initial heart failure symptoms, patient who have basically ejection fraction less than 40% who may go into heart failure, where there one needs to switch the patients to ACE inhibitors. Otherwise, we can continue ARBs because we have already discussed in trials like Optimal and Valiant that there was only non-significant difference between captopril and enalapril, captopril and valsartan towards the favor of captopril. Anything, somebody can add something to it?
Abhishek sir, Kamaldeep sir, Arvind sir, maybe you can highlight.
Yes. Good evening, sir. Nice presentation. The question is, how early do you think an ARNI can be initiated in a post-MI patient? Usually, as we already
Please
discussed, we start
raise your volume, sir. I can.
volume. Is it
Kamaldeep sir, your
audible?
voice is not audible.
Now
Yeah,
is it audible or not?
yeah.
It is audible. So, as we already discussed, we start with these receptors post-MI. In my clinical practice, I uh, uh, after the first discharge, like after discharge, and the patient is tolerating this receptor, then in the first, you can say the OPD visit, I usually check the hemodynamic status. If the BP is controlled and it is not, the patient is not hypotensive, not in failure, patient is clinically stable, then I usually switch over to this ARNI in the first visit only. And with the 36 hours washout period, then I start with the ARNI. And that too on the low doses. Like if the BP is allowing, then you see after adding this ARNI over a period of 1 month or 2 months, BP it starts picking up, and the patient who earlier used to be not tolerant to high doses, you can easily increase the doses in the subsequent follow because of the improvement in the hemodynamic status and this ejection fraction as well as the you can say LV dimensions, they are improved with the treatment.
Right. So you mean to say you don't introduce ARNI on initial admission?
Yeah, on the first subsequent follow-up, like with MI, with the dear wall MI, start with a low dose of the same inhibitor 1.25. If the patient is tolerating, after 1 to 2 days, I increase the dose to 2.5. Then on the follow-up, if the patient hemodynamics is allowing, then start with a half BD or 1 BD depending upon the blood pressure.
But if the hemodynamics allow you during the admission, will you like to start ARNI in those patients who are in heart failure and renal status is good, potassium is not high,
Sir,
and
actually, I
they
haven't
are,
done yet, but maybe
I
the
think, why
trials will
not?
come. The
What
trials will.
what did Paradigm HF compare? They compared in the basically, I think the patients who are sicker and hemodynamically stable, sicker means who had gone into acute LVF, whose anti-proBNP levels were high and had a massive infarction. There you can start because I am finding a problem in this washout period to explain the patient on OPD basis, and then what antihypertensive or suppose he is a hypertensive also, what antihypertensive will cover that 2 days? And that's a big, either you put on ARBs and then switch to ARNI. But I think you are absolutely right that patient should be 100% hemodynamically stable before you decide to put ARNI. Then Paradise MI trial had shown that you can initiate ARNI on admission, the first index admission also. Now we go on to the next. Post revascularization, if you find LV systolic dysfunction less than 40%, but without clinical heart failure in your patients, will you put on ACE or ARNI?
Ideally, we prefer the ARNI over the ACE inhibitor in patient of post-revascularization or post-PCI with LV dysfunction, because ARNI is little bit superior than ACE inhibitor in view of reducing the cardiac death and recurrent heart failure readmission.
Mhm. Okay. But there is a specific line in the question without clinical heart failure patients.
Yeah, patient is if severe LV dysfunction less than 40 years,
Hmm.
in clinical practice, we prefer the ARNI over the ACE inhibitor if patient is hemodynamically stable.
Okay.
If patient is borderline BP, then we start with low dose of the ACE inhibitor.
Okay. Actually, what I think the text says that if the patient is without clinical heart failure patient symptoms, you can initiation of ACE inhibitors is generally recommended, but the use of ARNI could be considered in patients who remain symptomatic despite optimal therapies of ACE inhibitor, ARB, beta blockers, and mineralocorticoid receptor. Uh, so one should start only ACE inhibitors in asymptomatic heart failure patients, and if even on if the patient continues to have goes into heart failure on ACE inhibitors, beta blockers, and mineralocorticoid, then you start ARNI. So in post MI patient, post revascularization, when do you like to start a beta blocker? Basically, beta blocker should be started once the patient is not in severe heart failure, should not have bradycardia or tachycardia more than 110, and patient is not in cardiogenic shock. Which is your preferred beta blocker, sir?
So in setting of acute MI, I usually prefer this beta lock because of short duration of action and the dose of 25 mg QID I start. And I prefer this beta lock in the acute setting. When the patient settled, then long acting like this,
Hmm.
you can say
Yeah,
Corcor
exactly.
2.55.
Before discharge, we can make it long acting also or on follow-up. Other beta blockers we can use is carvedilol and bisoprolol. Starting dose, I think 25 mg metoprolol tartrate, maybe once a day or twice, 12.5 twice a day and 25 twice a day, and up titrate till at discharge so that heart rate can be brought between 60 to 70. And then up titrate the dose every 2 weeks on follow-up till you get maybe 100 to 200 mg according to what is tolerated and what is required to bring the heart rate down to 60.
Not straight away in the post MI period, but in the OPD setting, when the patient dose has been settled, like this dose is required, then only we can, I think,
No, they
combine.
mean to, they don't, it means to say
Also, it's not a single pill, it's a
separate, not a fixed
and
dose combination,
okay.
but it is always advisable
It
to
is high. It's
first start ACE inhibitors within first day and then beta blockers. They have a synergistic effect. In synergistic means they are both helpful in reducing the cardiovascular mortality. So it is always advisable to start both of them, Cardace and Salokin, and discharge on maybe Cardace Mito. Very interesting question. Do you consider anti-proBNP as a deciding marker for choosing ARNI over Ramipil?
Dr. Abhishek? Abhishek sir, are you there? Arvind sir, Kamaldeep sir, you can highlight if you could.
I don't think so. Anti-proBNP will decide whether to choose ARNI or Ramipril. Sir, if you have any to say about that.
Kamaldeep sir, your voice is not audible.
Hello.
Yeah.
Yeah. Actually, I want to say that I haven't heard about any specific anti-proBNP level to choose between ARNI and Ramipril. Basically, if the anti-proBNP is high, then it will tell us the patient is in acute heart failure, or maybe you can prefer ARNI over Ramipril for a longer, you can say, for the long-term safety. ARNI can be preferred if the anti-proBNP is much higher.
I think you have aptly said that it is a prognostic marker, or in some cases, to decide between a COPD exacerbation or a heart failure. It is not considered to which ARNI should be used or Ramipril. Just your last point, I will like to highlight that high anti-proBNP level patients have poor prognosis. So if they can tolerate ARNI, so why not to try it at the initially only, so that they can have if benefits of both RAS inhibition as well as neprilysin in. Will you start a ACE inhibitor in patients with sorry. Sorry, I'll just. Will you start a ACE inhibitor in patients with ACS, whether revascularization procedure was performed or not, to get the mortality benefits?
Yes, I think the answer is yes. We can start ACE inhibitor to all the patients, depending upon hemodynamic status. If it is tolerable, then we start within 24 hours and uptitrate the dose according to the blood pressure levels.
Yeah, exactly. So there is no difference whether evacuation has been done or not. Finally, I want to, what percent of patients tolerate ARNI, 200 mg BD dose and versus Ramipril 5 mg BD?
Basically, less than 25% of my patients can tolerate as the high dose of the RNA 200 mg BD. Most of patients tolerate is the 100 mg BD. Due to main risk is the in high dose is the hypotension and the hyperkalemia. So give the 100 mg BD is the sufficient dosage most of patients.
Okay. Dr. Bansal?
Yes, sir. As the sir has already told, uh, I have my patient more than 150 patients there on this ARNI, and out of them, approximately only 2 to 3%, like 5 to 10 patients, they have achieved the 200 mg dose. And otherwise, mostly the patient they are on 100 mg dose, 100 mg BD dose. And the ACE inhibitor I usually use, you can say,
Actually,
less than 5% of the patients.
in chronic heart failure patients, almost the tolerability is same around 56-57%. But in our unstable patients, this tolerability is almost double in Ramipril group. So they are able to tolerate Ramipril more. Uh, I I have very few patients on 200 mg BD. I think only one or two. They are not able to tolerate because Uh, Generally, these patients have ejection fraction around 35, 30. So they definitely have a renal compromise. The renal blood supply is low. So every now and then patient will come, my urea has gone up, my creatinine has gone up. And then they also read Google and everything. So you cannot follow the guidelines every time. So there are only few patients where you can go up to the dose which are given in the trials. So definitely we have also given the patients 50 mg half BD, which is not indicated, no trial has shown. And first Indian brands had made scorable tablet. Now I think Biomada is also coming like that. So definitely the ACE inhibitors are more tolerable and we can reach the dose of 5 mg twice a day rather than full dose of ARNI. Anything? I think we have finished. It was a very good discussion, and I should thank MCure for such a good initiative so that we can also study a bit in our uh, busy day, busy in our patients, and we forget sometimes what we have studied during our DM time. So I really relished this initiation, and I hope we can continue with such things so that I definitely don't read without any presentation. So I thank you.
Thank you, sir.
Thank you, Dr. Arvind. Thank you, Dr. Bansan.
Thank you,
And
sir.
thank you,
for a
Kumar.
nice talk and nice discussion.
Thank you so much. Thank you so much, Rohit sir, Arvind sir, Kamaldeep sir, Abhishek sir. We really appreciate the time you all have, given dedicated for this event. And I hope that all the audience who have attended this session, they will gain some, expertise and their clinical relevance. Uh, so thank you so much to everyone. And in future, we also would like to connect again to collaborate and learn together. Thank you so much, sir, from the MQR CV team. And all the best to everyone.
Hi, Yogesh. We can stop the live stream. Yeah. Yeah. Just confirm me once it is done.